We'll go ahead and get started. So we're going to talk about making healthy property investable, and we actually have after these first couple of intro slides, have a poll that we would like for y'all to participate in by using your cell phones. So you'll send a text message code. This is a lot of numbers. So you're going to text the number up here, 22333, and then with your vote, obviously either yes or no. So basically the question is, do you view health promotion as an investable attribute of real estate?
Do we get to play?
Yeah, y'all can play too. So as you're submitting your poll questions, I'll go ahead and introduce our panel. So we have Dr. Chris Pike here, who many of you may know. He serves a couple of roles on our team. He has long been the Vice President of Research at the U.S. Greenbuilding Council. He's recently taken on a role as the Chief Operating Officer for GRESB, the Global Real Estate Sustainability Benchmark, which is a group based in Amsterdam that we'll talk more about later. And we have Dr. Matt Trowbridge here, who is a pediatrician and public health researcher, also associate professor at the University of Virginia School of Medicine. And he also serves as a senior research fellow at the U.S. Greenbuilding Council and leads a partnership that we have that I am able to work on with the both of them. And then we have Dr. Doug Judy, who is also a pediatrician and physician, doing built environment related work. He is executive director of the Build Healthy Places Network, which is a recently launched organization really meant to bring together the fields of community development and public health. And my name is Kelly Warden. I also have a background in public health. I'm a researcher at the U.S. Greenbuilding Council, and you'll hear more from us later. So we have a lot of yeses. We do view health promotion as investable attributes of real estate.
I'm curious if no works.
Yeah.
Let's just go.
Well, we'll dig in more to this in a bit. So basically, in case you need a little recap, basically what we're going to be talking about is, we all kind of have come to recognize that the built environment has an impact on health, as displayed by this lovely curated track in this really nice room with daylighting. We understand that the interior design of a building, also the exterior design of buildings and neighborhoods, has a direct influence on not just health outcomes, but also health behaviors. What we're not so good at is promoting the creation of healthy places at scale. So we have really great examples of sort of one-off special projects that were able to, for whatever reason, do a really robust consideration of health outcomes through their work. And we'll hear about some of those examples from Matt and Doug in their comments. But then we'll also hear from Chris about what can we learn from the green building movement in terms of how to move and transform the real estate market to really enable health promotion to become a systematic consideration of real estate projects throughout the country and ultimately throughout the world. So I'll hand it over to Matt to get us started.
Great. Well, thank you so much for joining us here today. We are really excited to talk to you. And I am glad that you already view healthy places as potentially investable. I bet embedded in that is you see it as potentially investable. Trying to figure out how to get there from here is exactly what all of us on stage here are engaged along with you in thinking about. And I think the way we're going to structure our conversation today, as Kelly said, is you're going to hear some stories from two physicians that have decided to join you guys in the green building world. And why might we have done that is part of what we're going to each tell kind of our own little story and talk about how Doug and I are each working on that in slightly different ways. And so I think the exciting part, kind of embedded in the unanimous yes, is health an investable attribute of real estate. I think we're all starting to see these projects around us that are actually, they really embody, I think, you can just tell they're beautiful, healthy places. They've even followed a really nice, there's moments, opportunities like in Nashville where they were able to, have a true community engagement process and that the design manifests that and reflects it. The thing is, I think, Chris has introduced us to this term that, standing back from the green building movement, one of the things that has done is helped move us from random acts of sustainability, to a more intentional acts of green design. And I think that's what we've started to realize, is that we're kind of at a more random acts of health right now within the building industry. And so it's nascent, but I think all of us want to get to a different place. And I think another thing that we wanted to emphasize today, and a different perspective perhaps that I wanted to emphasize today, and I think Doug and I will both do this, is that within the building industry, health is obviously a long-standing value, but it has been focused perhaps in very particular issues, things like indoor air quality and so forth. Absolutely very important things. But I think what I want to make sure, I think Doug and I are both going to emphasize today, is perhaps a different type of way of framing health than maybe most folks in the building industry are used to. So what this quote from Chris represents is, we're talking about, and maybe some of you heard Dr. Don Schwartz from Robert Wood Johnson speak yesterday. We're talking about not just individual level health of how the air in this room affects me, but also just how all the buildings we create together create a context that supports a culture of health. That how do we promote population level health? And so Chris has put out this charge to us. For healthy places to make a true impact on our nation's health, dozens, even hundreds of health promoting projects are really not enough. We really need to get to thousands. So that's an ambitious thing. So again, what I wanted to do to start us off our conversation this morning is to give my story on, an example how I have gotten to working in this field with you, and why I believe this is a really important thing for a physician to get involved in. And also give you a sense of how public health has been changing the way it thinks about the built environment as a part of a determinant of health, but also a potential avenue for improving health. And the way I like to do that is tell one of the classic stories of public health, which is the classic water pump of John Snow in London, he's often called the father of epidemiology. He was the man that when there was these cholera epidemics in London, he had the idea of graphically mapping where the person lived that had these cases. Because remember, this is before really robust understanding of germ theory and things like that. He started to realize that all of the cases seemed to centralize around one pump. And the classic story is, once he figured this out, that it was something to do with that water, he took off the handle, the cholera epidemic abated. But this idea of the way that environmental health and the built environment, so it's a long-standing idea in public health that the built environment is important to health. But it was, and this actually persisted for quite a while, just that very literal definition of, you see a sickness in your patients, you go into the environment, find a toxin, and remove it. For example, things like lead toxicity have continued that. Again, sitting in your pediatric office, child comes in with a constellation of symptoms that suggest lead toxicity, go into their home, remove the lead. And that's been a very traditional part of environmental health within public health for a long time. So again, built environment health, not a new concept. The difference is we are now starting to recognize that the types of toxins that we're thinking about now, they're different and they're bigger and they impact us in different ways, right? Just the way that we build our actual infrastructure, roads, whole cities, they've really changed the way we live. And they've, in many cases, we're living in these new environments that are extremely automotive dependent. And for just one example. But again, it emphasizes the idea of how the built environment at a population scale has a big impact on things like obesity. To be honest, for the last 20 years, we've tried individual level approaches at things like obesity, and we really haven't had the success we need. So we're starting to realize in public health that we really have to take this population level approach to things like urban sprawl and things like that to try to change the actual way that our environments prompt us to live. But it's important, again, I also like to emphasize that so many of these conversations around things, they tend to focus on things like obesity that are a little bit easier to get our head around. You should walk more, you should eat healthier. Great. But I think we all recognize that when you take that population level approach, there's so many aspects of health that have an environmental determinant and can be addressed through this approach of thinking about how the built environment impacts these things and then trying to do something about it. So what I'm really arguing for, but I also wanted to reassure you that public health in general is coming to is, environmental health perhaps needs to change. We need to get a bit more proactive. We can't just wait for the patients to come into the office anymore. We have to go out and do something. So we're really saying moving to a moment of environmental design. And I just wanted you to know that you have colleagues and collaborators in public health. The thing is, we don't necessarily know how to build stuff, so we really need your help, and that's really why Doug and I are here. So again, what I'm going to do with one thing I wanted to do is share a story about, again, how one of the most kind of inspiring things I've done in terms of, and how I've come to really think about how we can collaborate together. And that's the story. I had the amazing opportunity to collaborate with VMDO architects in Virginia on the design of a Buckingham Elementary School. It was a major renovation of a school that's about an hour south of Charlottesville, a very rural, low-income area. And the really amazing thing, as with many of these stories, again, a really unique set of circumstances came together, which ultimately hinged around a very visionary superintendent who said, childhood obesity is a real problem in my county. We're about to put $50 million into a school project. We should try to do something to promote healthy eating and physical activity. Can you do something about that in the school? And so the MDO and my team at University of Virginia and my colleague Terry Wong, we worked with VMDO, and we created first a set of healthy eating design guidelines that we thought could be, and we wrote down what we thought would be the ideal setting for teaching about healthy eating and promoting healthy eating in a school setting. And it goes through all the domains of the school, and we wrote down as many specific design ideas as we could. And it was an amazing experience for me to be truly involved in the design process and to understand the types of decisions that designers need to make. And ultimately, we landed on this idea of reimagining cafeteria as a classroom. That if we want teachers to be able to promote healthy eating and establish lifelong practices and attitudes, well, we should be using our cafeterias in a more robust way. So we did things like opening up making it transparent between the food service staff and the cafeteria to engage them more as teachers, and making sure that the resources they needed to teach were right there in the cafeteria. We also did things like take recommendations like the Centers for Disease Control's idea of water, making sure it's competitive with soda machines in schools, and we just really went for it. We thought about how to not just have water fountains there, but celebrate them with really high quality signage that's consistent throughout the school and so forth. We also did a similar effort around the physical activity. We created design guidelines through every domain of the school we could think of. And we tried to think through this whole host of potential strategies that could be employed in a school in all the different domains and where that could go, from things like wayfinding, signage, furniture, outdoor learning areas. Again, building a host of strategies that could be utilized. And they manifest in things like an active stair in the lobby, and also active furniture, which allows children to move and is shown to be a great component of reducing childhood obesity. And you can learn a lot more about the school project. I don't have time to go into today from the website wemoveschools.forward.com, and we're very proud of what we've achieved there. But for the purpose of our conversation today, I give that story mostly as a backdrop, because as we were so proud of this, and we still are so proud of this school. But as I sat down and talked with one of the principals from VMDO, Joe, who was incredibly supportive of the project, he said, the problem is, Matt, again, the set of circumstances that set up Buckingham, again, were one of these random acts of health. The problem is, as VMDO as a firm tries to think about how to move forward with this, really, honestly, we still don't really have a business model for what we just did together. It was an amazing experience. It happened, and we're a mission-driven firm, but we need a business model to be able to do this again. We need to be able to invest in health. And so he pointed me to the idea of the U.S. Green Building Council and LEED. And I was a few years ago. I really didn't know anything about it as a pediatrician. But the reason he pointed it to me was not because that LEED is the end-all be-all, but he pointed out as like, what I would recommend is you think about the green building movement as a model for maybe how you might do this. What he kind of pointed out was he's a very wise guy. He's also an introvert, so you have to wait a while to get him to talk. But when he does, it's gold. And some of the things he pointed out to me are, the reason LEED and LEED certification remains valuable to us is that it does it cues up a conversation with our client. It allows us to have a discussion about innovation. So if health could be somewhere in there, that would be really helpful to us. It provides a clear compliance pathway. Like, we know what we're talking about. If you want to get there, there's a pretty clear understanding with the client of what we're going to need to do it. And it offers a predictable recognition structure, value proposition. Like, you can invest in some green features, and if you do it and you follow the compliance pathway, you will be recognized by the market. Can't do that for health at this point. So that led to our current work together. So the partnership I lead with the U.S. Green Building Council and the Global Real Estate Sustainability Benchmark, funded by Robert Wood Johnson Foundation, who you heard from yesterday. And our basic premise and reason is taking the lessons from Joe and trying to expand them. So our goal, we believe that by applying green building principles and market transformation, we can move to a fundamentally different place of promoting healthy places. And ultimately, like the title of this session suggests, make healthy places investable. We feel there's two necessary strategies for this, broad strategies. At the project level, we need to empower built environment project teams to intentionally address health and well-being. Stop doing random acts of health and sustainability, integrate it in. Because we know that's a long-standing value, but being able to get there in a way that you can sell to clients, that clients understand what they're buying, we have to get there. And then you're going to hear from my colleague Chris, he's tweeting like as we're talking here. This is great. We also have we've come to recognize that to make that truly investable, we're going to have a portfolio level strategy. You're going to hear all about that from Chris, and that's really where making healthy places investable, that full cycle is going to be important. So how are we getting started? Well, one of the first things, so I said, okay, great, LEED, fantastic. Everybody tells me that there's lots of stuff that LEED is already addressing health in many ways. And so we said, well, let's look at it. And so the first thing we did was just looked at LEED 2009 systematically to look how health is actually represented. The thing we found is that absolutely health is an important value, and you can see it throughout the green building industry. But if LEED is one marker of where things are within the green building movement, what we found is that when you look for how health is represented, the terminology just alone was incredibly varied, which isn't maybe a surprise, but and also as a public health person, they weren't even the terms that I would normally use. I didn't know how to engage. And it made us realize that it was still hard for health teams to systematically and intentionally address health in this way. So one of the key things we're doing to try to move forward on that project level is our team is working to define a systematic process for addressing health and wellness within green building certification systems. And I use that last term carefully because we really don't see this as only a LEED-specific endeavor. Our goal is to actually, and we are doing this, create a process credit essentially that allows teams to systematically address health and know that we recognize for it. Our team collaborated with Enterprise Green Communities, and in their 2015 system, there is now actually a required credit that addresses health, and that launched this year. Our friends from Green Star actually have also taken a version of that credit, and that is live in Australia. We've submitted a health process credit for LEED for just starting review, and we expect it to be available in spring of 2016. And our team, part of our funding from Robert Wood Johnson is to help early teams, provide some technical assistance with this. And we also look forward to working with many other rating systems. We, of course, welcome and expect the opportunity to work with the WELL standard going forward. And just to give you a sense of it before I turn it over to Doug, is the way we're thinking about this is linking into the integrative process kind of concept that is growing, and it was very natural. It's actually a really, as I've come to understand it, it's a very natural fit for us to develop a health related credit. Essentially, as you guys know, as you engage in an integrative process, you're asked to do these simple box exercises for things like energy or water, and just quickly go through all the systems in your project and how they relate to energy and water and so forth to kind of organize your team's approach to these things. We feel that there's even blank space, white space on the bottom of that integrative process page that we think health and wellness actually make a lot of sense. Providing teams with that kind of simple box version of of how health and wellness might be addressed in that project, and then helping them have logic models that help them find strategies within LEAD, perhaps in other systems as well, that help, if they go out, we're going to ask them to go out and help them go out into the community, use public health data and community engagement the way a public health approach would, and then link those to specific design strategies that are available for use, and then make sure that they're recognized for going through that process, not just what they end up doing, but the process itself being certified. And we're very excited. This process credit is well on its way. We've paired up with Methune Design, whom I'm sure many of you guys know. They've done some really remarkable projects, such as the Mariposa affordable housing project in Denver, which to us, they've done pretty much what we're hoping we can scale up. You know, they had a fully funded health impact assessment that led into the development of their housing project, and they've done their own sets of measures and metrics to follow it. So similar to our work in Buckingham, we felt Methune was another project, a team that really understood this to try and do this. So they've agreed to help us find some early pilot projects for this, and have been trying to make sure we have a practitioner view on how we're developing these things going forward. And that's basically it for me. So as I turn it over, I hope that I think you understand why I'm excited as a pediatrician, why I feel very strongly and very comfortable that this is the right, an excellent way for me to spend my time and effort. And I also hope that you join us in, as we move on to the other speakers, let's think about how we can make healthy places investable, and let's try to get more, give you guys tools at the project level for being very intentional about addressing health. So thank you.
All right. Well, good morning. Thank you all for getting up early. I'm actually not that much on West Coast time because I've been traveling a lot lately, but it's really early on the West Coast. So as Kelly said and Matt said, I'm a pediatrician as well, and I run the Build Healthy Places Network. And so what I'm going to talk a little bit about today is the role of the nonprofit community development sector and how they're really beginning to try to engage health actively and look for investable opportunities and how you measure health and monetize that. So when I finished residency, my first job was in the town of East Palo Alto, California. And at the time, it had just been knocked off its perch as the murder capital of the United States by Washington, D.C., actually. And I had, at that point, 25 years of formal education and training. I thought I was pretty ready to go take care of the patients in this community, and quickly realized that, in fact, all that training was valuable, but wasn't really getting to what I needed to know. A lot of what was affecting the health and well-being of my patients and their families had to do with the social and physical environment they were living in, and I knew very little about that. The Robert Wood Johnson Foundation really refers to that as your zip code is more important than your genetic code in determining your health and life chances. And that's kind of a mind-blowing idea. As I said, after 25 years of high school, college, medical school residency, I didn't know that. And I really had very little idea how to engage that idea. And what we now know, and this research is fairly recent, is that these factors really get embodied. They get taken into your cells themselves and actively contribute to your lifespan and to your likelihood of getting a variety of diseases. And you can see the list of things here. You can imagine how those things really start to play out on a day-to-day basis for children and families trying to get by. The way this plays out, I don't know if you guys have seen these maps. These are maps the Robert Wood Johnson Foundation put together. So these are life expectancy at different exit ramps in cities across the country. So this happens to be New Orleans, and you can see on the top, 80 years is about normal life expectancy across the country. That's up near Lake Pontchartrain. 3 miles away, downtown, in a very low-income neighborhood near the French Quarter, the life expectancy is 55 years. This is current. 25-year shorter lifespan. That's equivalent to sub-Saharan Africa. Zambia and Uganda have life expectancy as 55 years, just to give you some perspective. Now, New Orleans is a complicated city. historically, racially, and a number of other things. This is a map of Minneapolis-St. Paul, arguably one of the healthier, wealthier, whiter communities in the country. Still, you can see in the lower left there, 13-year life expectancy gap, 3 miles apart, 2 different exit ramps. When they released this, one of the radio stations or TV stations went to visit these neighborhoods and interviewed a guy who lives in the neighborhood where the life expectancy is 70. I said, well, what do you think about this? He said, well, I'm gonna move 3 miles away. Like he knew what we all know when you see these places. So I got drawn into this field because a colleague of mine says that community development is in the zip code improvement business. I really thought of as a public health professional and as a physician that zip code, where you live, is just a socio-demographic factor that you have to account for in your research. It's not a changeable thing, and community development really addresses it very differently. So, got a little short video here.
Nearly 1/5 of all Americans live in low-income neighborhoods, where achieving the American dream is often beyond reach, where there are not enough opportunities for a good education, a good job, and good health. For decades, the community development and health sectors have worked to improve the lives in these places, working side by side, perhaps even with the same people, but often not working together. Today, collaboration across these sectors is growing. There are more places where community development and health are working hand in hand to improve both neighborhoods and the lives of the people who live in them, working to reduce poverty and improve health together. Innovators are leading the way, recognizing the importance of places where people live, learn, work, and play. For example, in New Orleans, the Refresh Project offers healthy, affordable food and health education, but also training and jobs as an anchor for workforce and economic development, improving health and improving lives. In the Gulf Coast of Texas, Neighborhood Centers, Inc. is dedicated to improving communities and the lives of people in them, focusing on 6 essential components: education, housing, connection, health, economic opportunity, and infrastructure. When a neighborhood reaches its full potential across all of these, the community thrives. In the East Lake neighborhood of Atlanta, Purpose-Built Communities has transformed a once struggling neighborhood into a vibrant, sustainable community by incorporating wellness resources with mixed income housing and a cradle to college education pipeline. Employment has increased from 13% to 70%. Violent crimes fell by 90%, and high school graduation rates are up from 30% to 78%. All of this progress is linked to better health. There are so many bright spots, efforts that are improving health and improving lives, helping people and places, from the urban apartments of the Mariposa Project in Denver, to the Fruitville neighborhood of Oakland, California, and the communities for healthy food in New York City. Examples from around the country show that we can, working across sectors, create better solutions and greater impact. The need to work together is strong, interest continues to grow, and outcomes are promising. But we also know that connections are key. The Build Healthy Places Network is the connector. It's the place to...
I'll stop there and save a little time. So that seems like a more fun way of covering some of that material than me just telling it all to you. It was an interesting experience as a physician and a public health person to actually create a video and pick voiceovers and music. You know, you heard the music was kind of peppy. So today, I want to cover a lot of stuff, so I'm going to move fairly fast, but we have time for questions at the end. I want to cover some of the scope and scale of what community development is, some of the funding innovations that are happening, and what are some of the advances in measurement. So, relatively recently, someone attempted to calculate approximately how much money is being invested into community development yearly, and the estimate was about $200 billion a year going into low-income communities, largely unknown by the public health sector and by medicine, and yet addressing many of the very social determinants of health that we had on that earlier slide. Nonprofits do the work. It's kind of an alphabet soup. Community development corporations, that's a term that comes from the 1960s. War on poverty. Corporation sounds really serious. It was sort of before we had the negative connotation. CDFIs, community development financial institutions, are nonprofit banks effectively that help funnel resources into these low-income communities. A lot of the money comes from state and federal tax credit programs, the low-income housing tax credit, the new markets tax credit. These are all within the last 20 years, 15 years. New markets tax credit is a job creation focus, whereas the others are housing. And then community development block grants. Really importantly, it's probably more like $150 billion a year. It comes from something called the Community Reinvestment Act. And that was put in place to fight redlining. So this is a map of Philadelphia in 1949 that just at the time was showing where the high risk and low risk loans were by color. Over time that became codified. Lines were literally drawn on maps and no loans would be given to those neighborhoods, even though the banks took deposits from there. Effectively, that stripped wealth out of low-income, predominantly African-American neighborhoods for decades. It's a huge part of why there's such enormous disparities in wealth now. CRA was passed to fight that. And I've been working with the Federal Reserve System for the last several years because they regulate banks on community reinvestment. And what they started to realize was that simply plowing it into affordable housing over and over again was not having the impact they wanted to have. It needed to be a more holistic approach. So community development used to be referred to as urban planning, or urban renewal, sorry. So urban renewal, this is a classic example. This is the Pruitt-Igoe complex in St. Louis. It lasted only 16 years before they tore it down, bombed it, blew it up. And they sometimes refer to that as the end of modernist architecture. An author wrote a book about the moment, the date and time that they imploded those buildings. It's important to remember though, Minoru Yamasaki was the architect of the World Trade Center, was the architect of Pruitt-Igoe. These were the smartest minds working at the time and the system failed. What we found through community development as we know it now, it's a much more networked, community-focused system than the sort of very top-down system that was true of the urban renewal of the day. So the zip code improvement that we talked about focuses on, so these are both, on the left is the Solar project. So the families actually there don't pay utility bills because they have solar panels on the roof. It's all affordable housing or public housing. On the right is supportive housing, which is the term for mostly homes for the homeless, but also other high-need individuals. That's in San Francisco. I used to walk by there. It's the kind of place you want to move into yourself, especially in San Francisco. Education, so charter schools are built by the community development sector, as well as early learning facilities. Economic development's also focused directly in small businesses, but also in the facilities that engage that. So the Baker Ripley Center is in Houston. That's the new downtown in the poorest neighborhood of Houston. You can imagine the impact that has on the families that live in that neighborhood to now have this nearby, in addition to the actual services. Market Creek Plaza is in San Diego. The population there is mostly families from Oaxaca area of Mexico, so they wanted the architecture to sort of resemble something that was familiar from home. This is an interesting example. Downtown Crossing, this is one of those that just came across my desk the other day, just as an announcement that it was being done. This is a $200 million investment in central Memphis, a really disinvested area. They're converting a Sears Roebuck distribution center into a multi-purpose facility. So things that are included in this, it's been empty for 25 years. There's a charter high school for arts and sciences, a teacher residency and graduate urban education program. It's going to serve 2,500 students a year. A wellness and fitness center, an art exhibition and art making facility. There's a clinic, a comprehensive cancer center, healthcare offices, 260 units of affordable housing, and it's expected to create 900 new jobs. The thing is, it's a little bit like Matt said, this was not necessarily intentional. I can say safely this is going to have an enormous positive effect on the health and well-being of the people that live there and the surrounding neighborhood. But the components of this project are entirely deal-based. It's where the money was available. Not that that's not a good thing, but little tweaks. Like for me personally, I think figuring out a way to get a daycare center or an early learning facility there would have taken what's an incredible $200 million investment and really amplified that. That's a sort of intentionality that I think we want to be considering. On a larger scale, this is Sunnydale. This is the largest public housing project in San Francisco. 50 acres of San Francisco real estate, occupied by 1,500 people, highest murder rate, STD rates, teenage pregnancy rate, dropout rate in the city of San Francisco. Mercy Housing, a large nonprofit affordable housing developer, and the related companies are redeveloping this for $800 million. So zeroing in, it's old Army base or Army housing. This is what it's going to look like now. So they're doubling the population, maintaining all the affordable housing, and bringing in mixed income housing. In the lower right there, you can see this is what they call the community hub. And that's going to focus in on, there's going to be a YMCA, a charter school, a bank branch, a small grocery store. This is the type of sort of large-scale investment. But again, this was, when I talked to them, it was, the components of the hub really came out of their own experience. And there was no literature basis for it in public health, and yet we believe that we can guide some of this work. But those are all those are all in the process, right? So just to highlight that this does exist. So this is Eastlake Meadows in Atlanta. This was mentioned in the video. Eastlake was called Little Vietnam because it was a war zone, not because Vietnamese people lived there. Families experienced, on average, 1 violent crime per year at the time that the redevelopment began. Purpose-built is unusual. They now have 15 communities across the country. They focus on a holistic approach, which is really important. Mixed income housing, cradle-to-career education, and community wellness, which includes public safety, with a backbone or lead organization that's helping coordinate everything. And what they found, this is the housing now. Again, this is all affordable housing. This is the recreation center. And this is the new high school. So you can just imagine the experience for the children growing up in this neighborhood. The children here are now experiencing, testing at higher grade level testing than the wealthiest neighborhoods in the city of Atlanta. And they remain 60 to 70% free and reduced lunch, which is a common measure of poverty. So those are just some sort of range of examples of the type of work that's going on. So in terms of funding innovations, just a few I want to mention. One is the Healthy Food Financing Initiative. That's the federal program to bring grocery stores and food into low-income neighborhoods. About $100 million has been spent over the last number of years. The Healthy Futures Fund I want to mention. This one is a consortium. It's, I'm always forgetting who. It's the Kresge Foundation, LISC, which is one of the C05 nonprofit banks I mentioned, the Local Initiative Support Corporation, and Morgan Stanley. $100 million, it just is being bumped up to $200 million for investing specifically in housing and clinics and trying to combine those. So this is a brand new one, just broke ground here in Washington, D.C. This is a $34 million investment. It's based around SOME, So Others Might Eat, S-O-M-E, the Conway Center. It's in the Benning Heights neighborhood of Washington, D.C., if you're at all familiar with the city. So it's going to be completed in a year and a half, and it's got a series of, it's 200 affordable apartments, a health center that's going to see 15,000 patients a year, a job training center, and it's across the street from a metro station. So you can see it's bringing together a lot of the important qualities. Really interesting new fund is this Healthy Neighborhoods Equity Fund. This is based in Boston. What they're doing there, it's an equity fund. It's the only one of its type in the country. Rather than making money off loans, low interest loans that are being given out and repaid, these investors are actually putting their own money really on the line. And what they're doing is they're taking advantage, they're identifying currently low-income neighborhoods with a high likelihood of gentrification. They're using this investment to capture that gentrification, buy property and preserve it for affordable housing, and allowing the increase in property values to repay the original investors. So it's a really interesting approach to bring new resources into this work. I want to just quickly mention hospital partnerships. Another new, these are 3, there's a handful of others. Children's Hospital of Philadelphia is building something called the Community Health and Literacy Center. They're combining 2 different clinics, a children's clinic, a city clinic, a library, public library, and a recreation center all into one building. And the hospital's putting its own money directly into that effort. Children's Hospital in Columbus, Ohio is investing directly into housing in the neighborhood. Like a lot of hospitals, for reasons that aren't entirely clear to me actually, are often located in incredibly impoverished neighborhoods. That's where a lot of their patients come from, and a lot of their employees come from there. So investing to make their patients and employees healthier is a good deal for them. And Vita Stanford I wanted to mention. This is the Stanford Hospital in Stamford, Connecticut. You can actually see it in the background of the bottom picture. They did a land swap there. On the back of a napkin, there were no contracts signed, interestingly. I forget how many acres were transferred, but it allowed the hospital the space to build the brand new glass high-rise tower. They tore down the public housing. Land that the hospital owned, parking lots and stuff, was then turned into this is public housing. that beautiful street there, and they put an urban garden, urban farm in the middle. Like I think it's like a 2-acre urban farm. So the families can actually go and learn how to farm and get food from there. And last, in terms of funds, this is really new, so I didn't even go into details, but the Medicaid is beginning to toy with the idea of especially providing resources for supportive housing for the medically fragile and homeless. There's also early evidence of investments. I just heard a couple days ago, United Health in Arizona is actually taking money out of their risk pool, which is what they have reserved for insurance needs, and investing that directly into affordable housing on the scale of $20 million. Because again, they're going to get that money back as a low-income, low-interest loan. And so they see that as an investment to protect their bottom line. So to finish, I want to talk a little bit about measurement. So Measure Up is a component of my website. It's an effort we've done to really try to wrap our hands around all the work that's going on now in this area of trying to measure health where it overlaps with community development in neighborhoods. We go from the very basic, what are we talking about with health, to really digging into mapping tools, measurement tools, evidence base. We try to make it very accessible to a wide range of audience, especially non-public health people, and highlight some of the things we like the best. So I want to point out just a couple of them. So one is the Stewards of Affordable Housing for the Future, SAFE. I'd never heard of SAFE. Turns out it's 12 of the largest affordable housing developers in the country. They took on their own, remember these are housers, took on their own, they have put together a 1-page, 5-domain effort to identify impact on health and the social determinants of health. They're now testing this across 30 sites across the country for feasibility. What I really like about it is you can see how, now there's another page I'll show you in a second. They've got 5 categories on the left with very specific measurable items in the middle, percent of residents whose gross income increased and where that data is coming from. You can see here, housing stability, community engagement, health and wellness, education, and income. So just an example of a really lovely, well thought out approach so that we don't have to start from scratch. The social impact calculator, this one's fun too, and you guys could test it out. So LIF is the low income investment fund, again, a bank basically, has put together, they realized that the impact they were having was more than just the financial return or the number of units of housing they were building. So what is the impact? They actually took published public health literature, created an actual calculator. You can put numbers directly in here. In this case, this is education. So what we know is that if kids graduate from high school, their health and many different aspects of their life is much, much better. So if you've invested in a charter school, you can show that there are more kids graduating than there were before. Why not think about taking credit for that? Lifetime earnings increase, societal benefits, mostly around criminal activity. You can see here, these are on their website. We now have a guess that a graduate from high school has a likelihood of earning $500,000 more. And you think about that economically for a neighborhood and frankly for the US Treasury. That's a good thing for all of us. And I'm going to finish up with this metrics for healthy communities. This is partly because Kristen, Kelly, and Matt really thought this could be of most interest to this audience. So this was put together by, again, non-health players. This is the Minneapolis Federal Reserve and a Wilder Research in St. Paul. What they've done is try to lay out a logic model. What are the steps between the original investment, the input, the activities that come from that investment, the outputs, what are the things you can count, the number of units of housing built or the number of childcare slots. Those are just outputs. We don't know whether the children are better off because they went to a pediatrician or went to childcare or got a house, but we're guessing they do. So the outcomes are really short, middle, long-term outcomes, ending really with this idea of population health. Did we improve the well-being of the neighborhood? What they've done is they created 6 logic models for you. You can see them listed there. It's a little busy when you look at it initially, but the goal is really that you or an individual would go in and use that as just a basis. You'd pull the pieces that make the most sense to you. And what I like about it is that it includes both health factors. You can see here mental health treatment program spaces, patient visits, immunization rate, health and well-being, self-report improves, and you get all the way over to population health, diabetes decreases, or emergency room visits decrease. But then there's also jobs created. So the New Markets Tax Credit program I mentioned is about job creation. So jobs created, more employable people, clinics. This is the community health center logic model. Clinics are a great way to start at a low level and work your way up to better jobs. So you end up eventually potentially have seen an increase in the employment rate for the neighborhood. This is supportive housing, just you can see it's kind of the same busy thing with different outcomes. What I want to zero in, and this will finish up here, is if you zoom in, you notice that there's the blue and the black. I think the most clever thing about this effort is that the blue ones are linked, live links to actual data sites. So if we zoom in on academic proficiency, it takes us to another page, shows Kids Count Center, the Kids Count Data Center, and the National Center for Education Statistics. You can zoom into national and state level, zoom into county level and city level, and if you do that, this is Kids Count, zoom into Maryland, you can look at county level education, third grade reading scores. You can choose the year, you can choose the format that it shows up. So rather than all this data being sort of just buried out in the internet, it's being collected in a meaningful way, and we're going to work on improving that over time. So it's searchable, I'll finish there. But my 3 points I want to leave you guys with. One is this rapid movement to engage health as an outcome in the community development sector. Great interest there in trying to measure health as an impact and as a return on investment. And a handful of new funding streams that I think we all want to keep an eye on and hopefully see more of in the future. So thank you. I will add, actually, these are just some resources. The Federal Reserve has the books at the bottom, Investing What Works and What Counts. Those are free online, and they'll actually send you for free the hard copies too. But there's a series of essays about how you can invest in communities.
So to summarize a couple of themes really quickly before we hand it over to Chris to take us on likely a fast, rapid stream of consciousness presentation. So, we heard from Matt about how public health is really learning and becoming, public health and healthcare are becoming both very interested in the impact that the built environment has on health, are really eager to partner with people such as yourselves that build places. We heard from Doug about community development, really starting to focus intentionally on addressing health through their work. And I think one thing to take away from that is community development financing is more inherently focused on addressing common drivers of health, such as job creation, education attainment, and so forth. So what Chris is going to be able to do is talk about available mechanisms to drive similar investments within market rate development, which is really what we're going to need to be able to do in terms of, in order to make a true population health improvement through our work. So, Chris.
Cool. All right, there's a lot to say. So hi, everybody. Thanks for turning out early after what was hopefully a fun night last night for everybody. So I want to bring this to a place where, as we kind of work through this progression, we started with Matt talking about the kind of the fundamental basis of why is public health engaged and what is the notion of public health, what is this connection? And in some ways, I just want to reflect for a second of saying, isn't it kind of incredible that we are now coming back to this connection? I mean, in the beginning, the connection between the built environment, like the basis of public health was an intervention in the built environment, taking a pump handle off the, to prevent the spread of disease. And here we are, 100 plus years later, basically coming back and going, by the way, we can make these interventions in the built environment and make ourselves healthier or not. So so in some ways, it's a big circle, and there's nothing new in this conversation. However, we have done a bunch of things in the meantime that make us, sort of need to rediscover this activity. So, but what I want to talk about is so Doug gave us a vision for how what we might broadly call folks who are essentially impact investors, social investors. How are they beginning to make change on the ground? If we begin to think, what are we going to need to do to bring that into market rate investing? And I want to use as a platform GRESP. So many of you know that my current gig is with GRESP, the Global Real Estate Sustainability Benchmark. It's an Amsterdam-based company, and our goal, our purpose, is to convey information from the property sector to institutional investors, banks, pension funds, life insurance, sovereign wealth, the source of the driver for most market rate. So it just as a tiny little introduction, what GRESP does, we really have three competencies. We assess the things that people invest in, companies and funds. We also provide objective scoring for environmental, social, and governance performance, and we provide peer benchmarking. And our purpose in doing that is to essentially help shareholders realize more value and manage risks associated with real estate. Our position in the universe is twofold. We really sit at the intersection between capital markets, billions, trillions of dollars of investment every month when you put money into your 401k or put money if you have a pension, that exotic concept. If you had one, someone on your behalf is taking a portion and they're giving it to David. No, they're giving it to Prudential or other entities who are putting it into real estate so that you get some of that money back. On the other hand, the real estate industry wants to convey its achievements to the capital markets. Everyone is comfortable doing this with dollars and cents, but as Scott Moldavan has pointed out, there's a lot of value that goes beyond the cost savings, beyond the dollars and cents, and at a time there is a lack of metrics, there is a lack of a conduit to take that information and bring it back to the capital market. So many of us have thought about this for a long time. GRESP does this every day. The difference, and I think this was the last kind of wind-up slide here, is that there's a distinct theory of change here. When it comes to GRESP, and when I think it comes to thinking about how we achieve large-scale change, the only caveat I'll give to what Matt said earlier, odd to be quoted in your own presence, but on the other hand, also, I think it was millions, thousands? I think we need millions of these projects. And so we're not satisfied with dozens, we're not satisfied with hundreds, we're not satisfied with thousands. Ultimately, to achieve population scale change at the level we need it, we're talking millions. And the place we get millions is by engaging with investors, because what investors are asking for gets considered, what investors want gets done. It is a top-down world. The ability to empower project teams to do what Matt showed us at the beginning comes from the resources that the investors put in and the priorities they have. So the question is, how do we increase the box? How do we make more room to maneuver to create better places? We actually know how to create better places. Now, and one of the ways we manifest this today is when we look at one of the things GRESP does is we provide information. We don't provide a certification. We provide a range of information. So this is a quadrant. All these little dots represent investable companies and funds around the world. 107 companies, about a third of them are public companies you or I could buy on the stock market. 2/3 of them may be private equity, things that, again, pension funds or institutional investors have access to. The crux of this, for this conversation, is there is a broad range of what's out there. The only thing I want you to take from that diagram of when it comes to environmental, social, and governance, there is a wide spectrum of performance out there, and what we understand about these is that dots in the upper right behave as financial vehicles with different levels of performance, different levels of risk, different levels of volatility from the ones in the lower left. Scott.
These are people that have volunteered.
They are voluntarily in there because their investors asked them to. And that's exactly right. So the issue is, and this is the punchline, we all think that we're converging, we're rapid, that all top companies are doing this. Aren't we all just doing the same thing? No. No, we're not. Aren't we all kind of converging on a common set of practices at the company or fund level? No, we're not. There is a lot of meaningful variation when it comes to environmental, social, and governance, and because there is meaningful variation, because that meaningful variation is correlated with different aspects of risk and opportunity, you should know if you're an investor. Okay, that's the punchline. Now here's the problem when it comes to health. So that map I showed you is about environmental, social, and governance. And don't get too confused by the social because it's not really health in the way that we think about it. So we'll get to that in a second. So this is the issue. So today, investors recognize that there is a spectrum of stuff, even among folks, as Scott points out, that are essentially volunteering. They could say no. They definitely could say no. But that covers about half the listed market in the U.S. and a goodly portion of the private market. So here's the problem. So I want to bring, this is just my little wind up into this, is that this is the crux of our problem. I'm up here with two medical professionals who can tell us why the built environment matters. Whether I'm ingesting lead, whether I'm being sedentary, whether Matt's research on more likely to get hit by cars and injuries and all this stuff. This is the problem. What's the difference between we can go to places like this, we can go to Grand Central Station, and I know that there's something different about Grand Central Station. I walk in, I am physically inspired. I think this is an awesome place to be. This is great. This is a psychological, for my psychological health, walking into Grand Central Station is great. For my emotional health, hanging out at Penn Station. How many people had hung out at Penn Station and had exactly this experience looking at this board? And it smells good, it's really comfortable, and that is a frustrating experience. I know that is not good for my emotional well-being, probably my contagious disease well-being, or a number of other things. The size of the rat I saw there was incredible. So there is a difference between the piece of property called Grand Central Station and the piece of property called Penn Station that goes to our emotional health and well-being and stress. We know this. I don't need a whole bunch of research to tell me this. I feel like I've personally conducted the study. Then, on the other hand, I know that there are places like the High Line in New York City that provide physical protection, access to recreation, access to health-promoting spaces. And I also know that the vast majority of what I see when I drive down I-95 and turn off to get a soda is that, where my built environment is injury-inducing, and as this person goes from their soda back to where it is they're going, this is not protective. This is injury-inducing. I know that there is both a qualitative and a quantitative difference between a shopping environment that gives me healthy choices in an accessible way and a more common shopping experience that gives me a whole lot of things that none of which are good for me. I would be hard-pressed. Actually, what I love, there's so many levels to this picture, but as I've been told, the reds and the oranges are supposed to connect with my inner primate to get me to grab stuff, and the good stuff is down low, so I have to bend, and okay, that's the Anthony Rabbits thing. Then we have the connection. Then I also know that this space is more socially connected, more physically active than this space, which I don't need a PhD to figure out is more socially isolated, and as Matt has done the research, it's more likely to kill me in a vehicle accident by a heck of a lot. So the question is, from an investor's perspective, those are all the same. The problem is I can't tell the difference as an investor, the difference between a company who owns a lot of the good stuff, and I know what good stuff looks like, and a lot of the bad stuff, and I know what bad stuff looks like. And let's be clear, there's a big gray area in the middle where we can debate, air changes and the off-gassing of the floor and the availability. There's a big gray area that we can maneuver. But let's just not forget that on the big picture, there is stuff that's demonstrably good, there's stuff that's demonstrably bad, and the crux problem if I'm an investor is it all looks the same. How do you expect me to deploy my if I believe you, and I believe that health-promoting property is good for people and likely to be more desired by people and consequently more valuable as real estate and lower risk because all those things are externalized risks that Doug was telling us about and Matt was telling us about. The question is, from an investment perspective, if I look on my Bloomberg terminal and I'm trying to choose between company A, company B, REIT A, REIT B, they look the same. I can't expect the market to allocate capital differently if these things on paper and in systems look the same. So I want to talk about how we begin to build, and this is really the story, the beginning of a journey rather than the end. I'm not don't expect the next 4 slides to take us to the end, but I want to give us a sense of, especially the work that the 3 or 4 of us are doing, the question is, where do we need to be in 2 or 3 years to expect the market to do something differently? How do we want to enable the market to literally be able to choose to invest your pension fund money in property that is health promoting? How can you allow the market to be able to ask the question? Don't you want, I hope I want, the people who are investing, if I choose an investment vehicle, I want to know, is that vehicle doing more or less to promote health than another vehicle? And the other question, which is kind of an important sub-question, who do I mean by health? Health for whom exactly? Do I mean health for the occupant? Do I mean health for the employee? Do I mean it for the customer? Do I mean it for the fence line community? Do I mean it for the supply chain? Do I really mean it for all of them? Do I care about them all in the same proportion? Because once we get to this point, that's going to matter. Do I want to invest in a property company who is creating health-promoting workplaces, using well, doing all this cool stuff? Do I want to ask, and now who do I care about in different proportions? A lot of the folks Doug talked about, we're talking about people who are in poverty, low income, they have a certain set of needs. If we go elsewhere in this conference, we're talking about extending the lifespan of Google employees to 130 years. All right, okay, those are both worthy goals. I mean, societally, I guess, they're both worthy goals, but they're quite different And then we go another room over, and we can talk about protecting firefighters from dioxins when I burn up PVCs, or the supply chain where I'm worried about labor practices and blah, blah. Okay, we're not clear on this point. And our lack of clarity goes back to the investor. If we don't know what we're talking about, and we're not clear and consistent and intentional about what we're talking about, we can't expect the investor to put money into something that we're not clearly communicating health for whom. Is it who? What is it? Okay. So so
Just a factor of different investors require different metrics.
I hope they do, but right now we're not giving them anything that's clear and consistent. So I hope and totally believe that investors have different preferences, and I hope that some of them will care about this a lot, and some will not care at all. That's great. I care about enabling either one of them, and at the moment, neither one is enabled. Neither. If you go on CoStar, you go on GBIG, you go on Real Capital Analytics, and you ask yourself, show me the healthiest buildings for occupants in this region. You can't do that. Show me the REITs that are more likely to be creating health-promoting properties like the one Doug showed. You can't do that. So if I care or I don't care, I'm currently disadvantaged either way. Okay, so I would argue that here's 4 things we're going to need to do together. One is we have to figure out how to assess this at the scale of the investment opportunity. That's typically a company and a fund. For most institutional investors, there's a whole world of direct investors, but we're going to talk about the things that companies and funds. How do we assess this thing? Second, how do we score it? What do we mean by good, better, best? How do we provide an escalation to help people understand what good looks like? How do we establish peers for this issue? These are the basic elements of differentiation. And the fourth one is, what do we envision as the kind of portfolio analysis that we're going to do? Because these are the things that we today have for environmental social governance. We can do all 4 of these things. We have done all of these things operationally, whether it's GRESP, whether it's Sustainalytics, whether it's a bunch of other companies. These are routine elements of how we currently manage everything other than health. Well, a lot of stuff other than health. All right, so systematic assessment. I'm going to give you just just some thoughts on each of the 4. And really, I'm going to offer you more of a contrast to say, here's how we do it with environmental stuff, with the sense of saying, 3 or 4 years from now, by the time Juan gets his PhD, he will have figured this out. So there's very smart people in this audience here. But the issue is, the first thing starts with defining the entity. We want to promote health in what? Do we mean a single commercial interior? Do we mean a whole building, a campus, a retail mall, or an entire company, or a school district? We are not clear about this. And from my perspective, we have the apparatus to engage this. If we want this to be a market rate issue, we need to make that assessment at the scale of things that people are investing in. The company, the fund. If I'm a public side investor, I want to make this at the scale of a school district. Who's taking out the bond? Who is the entity that the investor is acting into? And that the answer is generally not a commercial interior. That doesn't mean we don't need metrics for commercial interiors. We need those metrics to feed up to an asset, those assets to feed up to an investable unit like a company or fund. And if we don't have that information aggregated meaningfully at that investable unit, we haven't empowered the investor to make a choice. Okay. We also have to ask, why is that information being conveyed? How do we motivate investments to present that data? Because right now, we know, why would I present why would I go through the trouble of disclosing health-related information to my investors? They're not asking for it. It's more work. It's not in GRI. It's not in SASB. It's not. Why? Why would I do this? Now, the proximal reason is we need investors to ask. This is a little bit of an issue of advocacy. It's also a little bit of an issue of understanding what's possible. So the folks that Doug is working with, these were entities like the Federal Reserve are important. The Federal Reserve is asking, I want to know the health, and not just know, but I also want to promote positive health impacts from my investment. That leads to a cycle. The fundamental question there is, are investors asking about the health consequences of their investments? They're in the driver's seat, but they have to ask. They have to, and by extension, those of us who are involved have to know that that's the critical rate limiting thing, is the investor has to say, I want to know what I'm investing in. Is it promoting health? Is it leading or lagging? until the investor is interested in that question, until they see that as somewhat material, at least potentially material, to their life, this downstream process doesn't happen. So that question has to be asked of the right thing, an investable unit, and it has to be asked by the investor who is going to then put in motion a virtuous cycle. Okay. The third thing and last thing is we have to ask ourselves, what is the evidence we expect? Because I think health, more than many other things, when someone says, do you promote health? Like if I asked this of my school board where I live in Alexandria, they would say, oh, nothing stands between me and advancing the health of the kids in our school district. I'm personally sure that they mean that right until that sentence is done, and then they will go on to doing something else, okay? So more than other things, the issue is what is the evidence that we ask entities to put forward that they actually are dealing with health? And it is not as obvious as show me your utility bills. So we have an issue here of what do we assess, why did they answer, and what constitutes evidence, okay? So again, this is not the crash course, this is just I'm a little bit doing what Kelly was afraid I was going to do, which is stream of consciousness. But there are 4 ideas here. So the second one is objective scoring. Okay, once they've responded to you, once they've given you this evidence, now we have this problem that's actually back in our specialist domain of how do we score it? What does good, better, best look like? So we said this is actually a first-class problem because at this point we know what we're assessing, we have some data, and this is good news, but we're not done yet. Now we're not entirely clear what good, better, and best looks like. So we have these things. If someone tells me that they are doing, as Matt was saying, random acts of health promotion, they will give me a list of random good things they're doing. How do I know that that's what the people that they are targeting need? How does what they're doing match up with needs? And how good is it? Is it simply a good thing in isolation, or is it a really good thing? How do I know the difference? And when it comes, because ultimately we're going to have to reduce this to some kind of numerical universe, I need to be able to tell the kind of good thing from the really good thing. And I can tell you, I don't know how to do that with what Doug was presenting. I can know that some things are good things, but I don't know how to score them and differentiate them. In the GRESP universe, we traditionally do that with a level of peer benchmarking. So we basically say, here's what you're doing, here's what all your friends are doing, and if you're doing better than all your friends, you're great. Can we envision, when it comes to these different dimensions of health promotion, a similar enterprise? And can we set up that kind of peer group? Today, we do it routinely for management, policy, disclosure, water, risk assessment. We don't do it essentially for anything in health. This is a challenge. Okay, last 2. The other issue is this benchmarking. So if I say that part of this is comparing yourself to peers, well, who are your peers when it comes to health promotion? How do we understand peer groups? Are they the same as any other real estate situation, like Class A office to Class A office? Or a lot of the stuff that Doug showed us is diverse and multi-scale. It's a new civic center, it's a new school, it's a new something like this. What are the peer groups so that we can actually show those comparisons in a way that the real estate industry understands? Are you the best in what? Does health change our notion of peer groups? Peer groups are an absolutely essential concept because we live in a relativized world. I'm not 100% sure. And finally, I know what the end of the rainbow looks like a little bit. So I've told you 3 things that are hard, but 3 things that I believe are essential. But I want to kind of end on this notion of what does the end look like. Today, when it comes to environmental information, we know that investors do this. So this is a screenshot from Aviva Investors, which is one of the largest UK investors. They also have some presence in the US. For every single piece of real estate that they invest in, they collect information from GRESP, and they get essentially a dashboard. The orange dots on this thing, which you can probably barely see, are many, many, many different dozens of investments that Aviva makes into real estate. The green dots are the GRESP universe. A couple things to show you. One is they track this. They ask their investors, they assess their investments, they get the information back, they plot them out there, and they know which of their investments are leading, which of them are lagging. And what this does for them is they have a conversation. What they don't do, which you may think they would do, is they say, I'm not going to invest in that lower left. I'm not going to invest in the low performance ones. They don't say that. What they say is, I'm going to know where my investments are, and I'm going to engage with them quarterly, annually, to help them on a journey over the duration of my investment to be better. And so as an engaged investor, Aviva is using this environmental, social, and governance information to move their portfolio up and to the right. It starts by knowing where they are, and it goes toward doing better. Okay, so we know that they do this today. They go in, they sit down, they talk about carbon, water, waste, and so forth, and they encourage their investments to do more in terms of management, policy, monitoring, and performance to move up and to the right. They know what leadership looks like, they know how to engage, and they know how to analyze the risks and value of under or overperforming the market. I can say there is no equivalent in health today.
Do they do that for their acquisition due diligence?
They do it for both. Although typically, so the question was, do they do this for acquisition or do they do this for monitoring? They do it for due diligence, but the actual lion's share is on monitoring current standing investments. So they monitor what they're invested in. That also is a tremendous opportunity because these are all pieces of real estate on the ground that are doing more or less to promote health today. But we don't know. I don't know if the dots in the upper right are the world's most health-promoting properties on the planet, and the ones on the lower left are not. We don't know, because we're not collecting the right data. And consequently, I can't expect this investor to do something different to engage with that investment, to move their portfolio, because the data's not there. But I do know that over the next couple of years, we can use this, we can change this, we can add health to this, so that this investor 2 or 3 years from now can consider health, can move their portfolio up and to the right. And for those of you who are on project teams, create more space to do stuff well. So that when your projects are, when you're interacting with your owner and your investor, they're giving you a bigger box to design in, a bigger box to do better stuff because it's contributing to a bigger picture. So let me close out my part of this by saying, my hope is that today, like I told you, our problem is not that we don't know what health promoting or non-health promoting looks like. We know the difference between Penn Station and Grand Central. We know that. We don't need volumes of research to figure that out. But what we do need are the ways to convey that information meaningfully and actionably to institutional investors to help change how capital flows. So rather than question marks all over these buildings, we want to have information on these buildings and be able to tell the difference. So with that, I think we're going to switch to Q&A. And I appreciate you listening to my ramble. So
we're going to have a little bit of moderated discussion up here for a bit, but then we hope that there's lots of questions in the audience that we want to get to as well. So be thinking about those and prepared to walk up to the microphones in a short little bit. So, Chris talked about the need for supporting evidence to build this case at the portfolio scale to kind of enable and empower the investors to make decisions about where they'd like to invest their money. And presumably, we're going to need to engage public health and healthcare professionals in creating those metrics as health metrics related to health. So Matt and Doug, could you talk a little bit about what green building professionals and what real estate fund managers and institutional investors should know about public health and healthcare professionals? Are public health professionals used to thinking about health promotion in this way? What should they expect?
So I'll answer the last part of that, I think, because I think what you're asking is, as we run out of this room and try to do this work, I think it is important to, as Chris said, to just recognize where we are. I think what you are going to find is that there are a few of us in healthcare and in public health that are trying to take this seriously, try to move beyond. There's general acceptance that this is important to do within public health. There is limited understanding of how the built environment comes to be within health. A lot of the things we're talking about here today, and the reason why Robert Wood Johnson is funding both of us to do this work is that both sides of this equation are necessary. Having you guys jump in and understand a public health perspective and how to think about individual health and population health, and take your mechanisms and point them towards health. Very important. But to Kelly's point, public health has work to do too, and I promise we're working hard to do it, which is the real work of Buckingham was translating what we know into actionable design guidance and so forth, and that is going on. But I think maybe to your point, it is important to recognize that's where the state of it is. I think one thing I did want to just jump in and just say, as I'm listening to Chris, I agree that we are in this very early stage of these things. These things aren't super well defined, but I've become convinced by working with you and listening to the way investment occurs currently in the building industry, that even just starting with things like peer benchmarking and there are some naturally occurring leaders at both the portfolio scale and the project scale. And so just paying attention to what they're doing and just having a mechanism by throwing out the types of practices that they're starting is a great place to start. So anyway, that's my first take of that. But Doug, what about Kelly's question?
Well, I'd say, excuse me, I think a big picture issue is that in medicine and public health, we're very good at measuring disease. We're not very good at measuring health. We don't even define it very well. And as we all know, lack of disease is not the same as health. And so that's sort of a big picture issue in terms of what we're working on within the public health sector. The other piece, and I think is really critical, is I sometimes see, and I see this with my community development colleagues, there can be an impulse to jump directly from an investment, say in affordable housing, high quality affordable housing, to medical outcomes. Reduced asthma, reduced obesity, reduced type 2 diabetes. Those may be long-term goals, but they're building affordable housing. It's not a diabetes intervention or an asthma intervention, it's a house. What the impact will be, do you feel good about the place you live in? Do you have better access to all the things that you need to run your life? Those, in my opinion, should be those are the shorter term, more proxy measures. We know those things are tied to actual health and longevity. But I worry sometimes that the sort of building community, the community developers, the developers themselves jump directly to the medical outcomes. And what I do think we do have there are examples within public health, things like self-reported health, or things like, there's actually validated measures of community safety or opportunity. Now, opportunity is a much better measure of what a family might achieve in a well-designed, well-placed, affordable housing. Let's make that the primary goal. We actually know, we have evidence to show that higher sense of opportunity is actually tied to better health. So we don't need to jump all the way to the medical outcome.
Building on that, because this is a really important point, because this issue that kind of, one thing I might take from having hung out with you guys a little bit is that health occurs on the margin, essentially. In a sense, and what I mean by that is saying, we create a healthier home, a healthier workplace, a healthier neighborhood, and I go into that place and I see an obese person. That is not like a failure of this. I think there's a very deterministic lens that the architects or engineering and construction industry tends to have, is saying, because we live in a pretty black and white world, this building stands up, we want that to happen. We don't want there to be ambiguity in the fact that this stands up and it doesn't fall on our head. We just want that to be true. However, the things we're dealing with populations of people we're saying, if I create better access to local services, walkability, certain levels of indoor air quality, I am going to, on a population basis, make some shift the distribution of comfort, shift the distribution of nutritional choices, shift the distribution of physical activity. It's not about the experience, it is ultimately about the experience of individuals. We're really trying to shift the frequency that people walk, shift the frequency of their choices, which ultimately at the population level lead to changes in healthcare costs and outcomes. That is I think, one of the most existentially different ways, because if you make it the other way around, if you want these things to be deterministic in the way that we hope that this building is deterministically staying up, that's not how this problem is going to look.
Well, it's interesting that you bring that up, actually, because this is another instance when we can learn from the green building movement, right?
That's right.
I mean, when you're creating a green building, the architects, designers, engineers, construction managers are making certain design decisions, hoping that the people that occupy that building will use the building as it's intended to be used. But we know that oftentimes people get in there and the systems don't work the way that they're supposed to, and we don't get the energy efficient responses that we're looking for, or water savings or whatever. So how has that been addressed in the green building movement? It seems like green building has been able to accept that there's going to be, yes, we do something and we intend and hope that it will have this outcome, but we're not quite sure all the time.
We're deeply, this is a great point, Kelly, because we're deeply conflicted on this thing. Like, we know, actually, I'll even go back to kind of the cornerstone of the controversial history of green building. You know, the landmark studies that show that, you know, green buildings do or do not do something with energy efficiency. Okay, what those studies actually show is that 80 or 90% of the time, buildings do what we designed them to do. And we get really bent out of shape that 10, 20, 25% of the time they don't. Which for me as a scientist, statistically, these things are largely doing what we say.
That's a great point.
But as engineers, we really worry that there are instances where they don't. And so I think there's a bit of a epistemological problem. Is that, you know, are we okay with green buildings as a market intervention? That yes, by and large, in the vast majority of cases, are doing what we want. And to what degree do we worry about 5, 10, 25% of interventions that aren't? Doesn't mean that those, you know, underperformance is not important, but it does mean there's a different mentality, and which I think is more common to public health professionals.
Can I just add to that? I really want to make sure that nobody leaves out of this room today feeling like you are personally responsible for obesity prevention, because I promise you we've been working really hard on it, and it's hard. So that's not the goal. Actually, what I meant also by there's part of what I am. You know, any good presentation should tell the audience something that I want them to go out and do. And what I really want you to do is engage in this conversation. Be part of the education effort for the public health world that really wants to engage with you. But I think what I've taken away from the green building movement is you defined a set of actions that a project team can take and they change over time, sure, but there's a defined set of actions that can be taken in a project that roll up to a good green sustainable building. So what public health will not be able to define without your help is what are the actual actions you take during a project where we could affect your design one way or the other to promote health or not. And then at an investor scale, same thing. What are the actual actions we are not describing a future where a portfolio fund, you know, is thinking about obesity prevention all the time. Ultimately, they're going to be, well, the things that investors can or can't do one way or the other, which of those promotes health, and let's consistently try to do those. So what do? Please stay engaged and go out there and know that you're part of educating public health as well.
Well, and going back to engaging with the investors, Chris, could you expand upon a little bit why do investors care about GRESB, and to insert health into the conversation, do we need to go convince a number of investors to care emotionally about health, or do you believe that health promoting attributes are bringing value to those portfolios? And to build upon, you know, Matt's comment about the naturally occurring leaders, why are those naturally occurring leaders within the investment world thinking about health in an innovative way?
Yeah, I'll give you two different reasons, and then I would love to turn the question to Doug and ask the same question of, you know, why does the Federal Reserve Bank do it? So to answer on the equity investor side, the reason that the GRESB universe exists is originally you had sort of European pension funds who said, we care about how our money is being invested. And they were generally low carbon investors. They're saying, we want to understand the carbon impact of our investments. They also have sort of, at the time, sort of strong ESG screens, you know, cluster bombs, nuclear weapons, you know, the child labor. But what that is interesting is that we believe that our fiduciary responsibility, the things that create value and contribute to risk, are related to pieces of information we don't have. We think exposing ourselves to companies that have those practices is a risk. We think that that there is a dimension of high performance that's not captured in financials. And so we're going to use this mechanism to ask that question of our investments. That has turned out to be successful, and that is spreading. As I said earlier, I do think that investor engagement is not a benevolent issue. It's an issue of that higher performing assets, i.e. those that are promoting health outcomes, that are providing superior occupant experience, under some circumstances are simply more valuable. They are differentiated, and they also may be less risky. At the bare minimum, you should know the difference. That's my bottom line for the investors, is saying, whatever your opinion, I don't understand the basis for not knowing. And I think that whether you're CalPERS and you're now saying, we want ESG information for all investments, that's the right starting point. Don't worry about the performance until we have the information. I mean, Doug, I'd love to hear, just to turn it on you, so Federal Reserve Bank is not the first name in town to think of when you think public health promotion, at least as a layperson. Right. So why?
Yeah, so I was shocked as well. I mean, the root of it is what I mentioned around the Community Reinvestment Act and the regulating of the banks and the recognition that it really isn't. Well, this is important. So what people often don't know is the Federal Reserve Bank of the United States, it's our central bank, has a dual mandate. It's the only central bank in the world that has two main purposes. One is to maintain a stable currency and control inflation, and that's what you usually hear about. The other, which actually has gotten a lot of press recently, is at maximal employment. So the Fed defines low-income neighborhoods, and I find it fascinating because it's very different from the way we do it in public health. Low-income neighborhoods are underperforming. They're a drag on the economy. So it's less about the rights of anybody living in those places. It's about everybody else's rights or everybody else, just the overall economy. And what I like about that is it's a very different, it's a different political way of thinking about it. It's reframes it in a really valuable way. That if you want these individuals, these families, these children to grow up to become productive members of society, you have to invest in them. And so what they started to recognize was a lot of the CRA investments were going into affordable housing. And we have seen that affordable housing by itself, I think of it a little bit as vaccinations. What they've done is sort of sprinkled vaccinations through a neighborhood in the hopes that everybody kind of gets what they need. That holistic, like you guys saw purpose-built communities, vaccinations have to be given in the right order, the right number, and in the right timing. And if you do that, you're actually completely immune to disease. But if you just were to fly a helicopter over and sprinkle them, you're going to have effectively no impact at all. And that's unfortunately the way a lot of the anti-poverty investments have been happening. And you can see the scale is pretty large. So a lot of what we talk about is not the need for new resources, but about aligning the resources. And it really is very applicable to the larger, this happens to be low-income communities, and in a way they need to be a focus because they are the bulk of poor health and the costs. But the majority of people are not poor. So actually enormous amounts of poor health are obviously happening in non-poor people. And so it really, these ideas apply elsewhere.
That's awesome.
So one last moderated question before we turn it over to the audience. We were talking, Matt mentioned that yesterday we were able to hear from Dr. Don Schwartz at the Robert Wood Johnson Foundation, and he talked about how context leads to culture. You have a really interesting story about tomatoes in Italy. He also highlighted that green building professionals are in the business of creating contexts. And we're hoping that through this work we're able to provide those professionals with tools to promote health through their work. As we talk about interventions at the portfolio scale, how do they empower innovation to occur at the project level, at a building by building, interior by interior basis? That could be.
Well, let me just start there. For me, that's been this is still very much the new part of this work for me. Doug and I have to remind ourselves all the time that we started off as pediatricians, and suddenly we're talking about portfolio level managers. But I think the reason...
Capital stacks.
Right, yes. What I've realized though is the reason I care about this, and I think it's critical is when you do work something like, you get a chance to collaborate on something like Buckingham, and you have someone like Joe Celentano who is totally dedicated, and they want to keep doing this work, but they genuinely need to solve the issue of how does my firm keep doing this work. What I realized is I just kept, the researcher in me was just like, well, we keep having to find who is the big fish that we need to change, and you start thinking, okay, well, it's the developer, right? And then you find out, no, it's not actually. The developer ends up asking for money, and even that layer of person asks for money, and until you get all the way up to, Howard, is it Dr. Koh, Assistant Secretary, former Assistant Secretary for Health, he has a great quote that he talks about. Sometimes we're focused on the goldfish, but it's actually the water that is really the important thing. And I think in many ways the portfolio managers are really the water that all of us working at my heart and soul will probably still be at the project level, but we've got to have water around these beautiful goldfish if we want to keep going forward.
I'll take a stab at that too. I think that one thing you said that two things that I think are really important about. One is I think that this notion that I'm not a big fan of the word healthy building. And the reason I'm not a big fan is I think a building or a space is a platform for health promotion. And this is the lingo that Matt has got in my head. I like this notion that it is a platform. A building, to me, is not a health thing because people have health. It is a quality of people, not a building. If you take I don't know what that means. So what I do know is that a building or a neighborhood can be more or less health promoting. It can expose you to toxins, it can moderate your behavior, it can influence your choices. Those are the things that we as designers, architects, and engineers, we are creating a platform for health. And thus, that same thing applies at the portfolio scale. And obviously, I've talked about the investor-owned. I think, in my mind, it's easy to think about this within a school district. A school district is a portfolio. What Matt did with VMDO and his colleagues was essentially an awesome random act of health promotion within a school district. The win is that is adopted at the population level and made systematic practice, so that it's not like a great project team that pulls it off at one elementary school under one rando circumstance. That is great. But it's great if it's institutionalized and then deployed strategically as an intervention against the population of kids in that school district. And I tell you, me personally, like my kids go to school in Alexandria, like I mentioned, and Matt, they got a new cafeteria last year that embodies everything that's not in Matt's health design guidelines. And I go in there every day and pick my kids up from this cafeteria, and I go, that is a tremendous lost opportunity. Yep. So on one level, the fact that I'm aware through Matt's work that that's a tremendous lost opportunity, the people involved are clearly not. No, so whether that's the design team was clearly capable of using those guidelines and giving my kids a healthier cafeteria. The school district should dang well have had better policies to use those ideas to make every cafeteria have those qualities, but they didn't. And so it's not a failure of that design team. They were perfectly capable of making a much better solution for those kids. They were not allowed or empowered or timelined or VE'd or whatever the whole problem was that made that not happen, and that's the problem. So I kind of root this up to Matt's point, who's the goldfish and who's the water? In that case, the project team it's the water that in the case is the school district, and asking, is the school district kind of empowering the project team to make the right choices that give my kids a healthy cafeteria that helps them make good choices? And I think that whether you're Google or whether you're a school district or an affordable housing entity, the issue is still you have a broader context about where your property development and operations come from. And let's tackle this at two levels. We want better tools for the project team to help them know that there's a better way to design that cafeteria. If they didn't know that, that's a problem for tools. If they're not empowered to do it, that's a problem at the portfolio. And if we're clear about which scale we're tackling, we'll make progress faster and more meaningfully.
I would just add one thing. So I worry sometimes when I speak to these nonprofit developers. I mean, they're all working, they have no time, and they often will see no resources. You bring up health, and they're like, oh, one more thing, right? I don't have the time, I don't have the staff, I don't have the resources to address this. But if you frame it, they're creating health. They're not measuring it. It's a return on investment, an unmeasured return on investment. It is valuable. As you said, Grand Central is creating healthier people than Penn Station is, God knows. Yeah. That's valuable to somebody, and it's specifically valuable to the medical system. We spend $3 trillion a year on medical care in the United States, and we have far worse health outcomes than any other developed country. 1% of $3 trillion is $30 billion. 1%. You wouldn't even notice if you skim that off. And you think about what the scale of what $30 billion could be in other things. So there is a real impetus, and we see that it's really cracking the back of our economy in many ways. There's an impetus to identify this health value that's already there. Mm-hmm. We don't measure it very well. Right. It's true. But you have to ask the question. And then we need to really identify who is benefiting from this. The other issue really related to this is what we call the wrong pocket problem. This healthcare savings from, say, high-quality affordable housing or just, a well-designed community is accruing to the local hospital or to Medicare, right? They should be paying for that. We need to be able to make that argument, and I really think it's the same thing is true when we think about, how do we we need to engage basically the buyers of health, the sellers are creators of health, and how do we get the two connected to one another?
Which in some ways, this is what Matt's put. This is why the green building. This is like our bread and butter. Like
Right.
when a physician says we have a raw pocket problem, we're like, oh, split incentives. Okay, we spent 20 years dealing with energy split incentives. I mean, there are people in this room who, like, as if this was a new problem for us. I mean, not like we solved it, but as if this is a new problem, right?
This is what's exciting is we can use your experience already and apply it to another problem, which is very similar. Yeah.
It's so exciting that I cannot help but pitch it. I want to make sure you also hear that this is the entire premise of the next 3 years of work that we've been funded to do with Robert Wood Johnson. So watch this space. It's not doom and gloom. It really is, we think we have some ideas, and actually our team just wrote a paper that was published by one of our most prestigious entities in healthcare, the National Academies of Medicine, and it's entitled Applying Green Building Principles of Market Transformation to Promote Healthy Places. So you can find it, actually we have a preliminary project website at greenhealthpartnership.org, and if you go in there and look under publications, it's preliminary site, but you'll see some good stuff. The point is, that really is the argument that we think holds strong, which is you guys know a lot. You've built a movement, and watching it just objectively, I really do think that if we stick to the principles of green building market transformation and just stick to them the way that they've been employed, we can make progress on this health issue.
I feel compelled. I mean, a lot of this is what's in Scott Moldaven's book. I mean, a lot of you guys know. I mean, Scott is like luminary in this for value beyond cost savings, and Scott's down here in the front row. That is a lot of the things Matt just said. Where is that codified in our literature? I mean, that's one of the places that these ideas is not like. Again, it's not like these are new ideas. When we're writing those things, but they're a direct extension of this.
So we want to hear from y'all in the audience if there's any questions or ideas or general reactions. So if you could walk to the
grab
microphone,
something.
that would be really helpful.
I work for the University of Virginia, and you would think in a public school system or an institution that maybe it would be easier to implement some of these things you're talking about. But we have Aramark, for instance, who the university contracts out to deal with all of their dining and food. And so I would say this gentleman mentioned something about ease and, well, gee, I don't really have time to kind of deal with figuring out another way to contract or to implement these changes. And so I would say the contract side of it and the bureaucracy and how to effectively make a difference there would make a huge difference, because a university environment, to me, or a school, is a perfect place to implement a pilot program, like Buckingham, for instance. But if you came to UVA and we start talking, I'm going to say, well, we can't even have food trucks come on grounds because unless Aramark says, this is acceptable. Right. There are a lot of regulations around how they do these contracts, who they contract with, and I think Aramark, not to pick on them, they're just a very large company, but understanding their policy, they're going to jump on the bandwagon only when they see that, oh yeah, this is what the students want, this is what's going to be the thing. And so it's getting in to the early stages of what happens there with contracts. Does that make sense?
Yeah, absolutely.
It does. Actually, I would say a big one, another engagement of the Green Health Partnership Group is with groups like the American Institute of Architects, really calling out their ability to do things like they provide a lot of the standardized contracts that the bulk of architects use and so forth. So asking questions, and we are engaged with them and asking questions like, what is a performance-based contract that starts to bring in health and wellness? What does that look like? What are how do we defray concerns about liability as you say you're taking these things on? So you're totally right. I think again, the part I've loved about working with green building is that, again, it kind of has its own answer for that too. When you look at the diffusion of innovation curve, here we are sitting in this room talking about what does it mean to define ultra high performance. But the other aspect of diffusion of innovation is, at some point, as good ideas make it through the bulk of the market transformation, they start getting into the laggard thing of like, okay, it's kind of time to make this part of code, or change the law, and things like that. So I think there are mechanisms for doing all the things, and basically you have to, whoever's decision it is at University of Virginia to hire the food vendor, somebody has to be enabled through a code or a law or a policy that says we only use food vendors that allow X types of practices.
So I'll add two things to that. Two things that I think is really interesting. A, you look at the history of green cleaning, and you think, how can we learn from the adoption rate of green cleaning to push this issue? Another issue there of benchmarking. That's an issue where that procurement is just seen as standard practice. There's no peering. So how can we expose that decision to some peering with some metrics to say, as my colleague Dan Winters was in the room for a second, he loves to say, be first to be second. All these folks who manage those programs love to be first to be second. So how do you find the first, put them in a peer group, and then drive change into that decision? Yes. The third thing that I think, just because I'm soapboxing on it, is saying I think that I would love to think that educational institutions will be on the vanguard of this. But I don't see evidence of that, and I look at that. I won't call them out explicitly, but the large Maryland school district that is nearby. You look at they are often recognized as one of the most progressive green building actors, and it's related to this. The issue is they conceptualize their green building program as a way to reduce their OpEx. It is simply an OpEx play. They want to reduce the energy and water spending in their facilities. Mm-hmm. That's where their metrics are, to what Doug said. Actually, God bless the U.S. Air Force, they're the exact same way. Right. They rate energy and water. That is what they care about in their green building program. That's what they measure, and actually, if you look at this, you look at the data, schools underinvest in IEQ relative to other property types. That's crazy, but we're not calling them out on it. So anyway, I would just say that if we could provide, I totally recognize what you're saying is real. Yeah. We could provide some more context and some peer competition at that point of intervention, maybe.
Right. Whatever it takes to make it easier to say yes.
That's right.
Very early.
Yeah.
It's just simple as that.
I would, if you're not familiar with it, the Sustainable Purchasing Leadership Council, for folks that's a new thing specifically on purchasing. And actually, it's a really nice, today it's a guideline, it's moving toward a rating system that's really specific on purchasing. And so that's a new group.
Yeah.
Cool thing.
Thank you.
Yeah, I would add too that an idea came to mind, which is when we were in residency training, it was very common for hospitals, if they came under any sort of financial issues, who do you lay off first? The case managers. Yeah. Those that help the patients figure out where they're going to go after they're discharged. Why? Because frankly, a patient gets readmitted, more money in the bank.
Yep.
That has completely been turned on its head by the Affordable Care Act. Now, if you're readmitted for the same issue within 30 days, you do not get reimbursed. The hospital eats that charge. So what that means is those case managers are now the most valuable people on staff. So it's kind of a matter of figuring out where the incentives, and I was just thinking the UVA example, it's not an easy one, but maybe UVA is in dramatic competition with other elite colleges that have food trucks. They don't. They're losing students who see that as a hip, if they're, that sort of thing. Who benefits from the food truck idea? Because then the university will spin on a dime, right? Right now they're doing the routine. Yeah. And so it's a matter of identifying who benefits and where the incentives are, I think, sometimes.
Yep.
Yeah.
There you go.
Thank you for this very interesting panel. I barely checked my emails, so you guys were really
That's a modern science.
That's the ultimate feedback. Thank you.
And I really appreciated the bird song at the beginning of this panel. It was a great move. I've been thinking about this and related issues for a couple of years now through the Biophilic Cities movement. Yeah. And I'm working with your colleague, Tim Beatley,
of course, in
the Biophilic Cities Network. And so this idea of how do you get investors, the public, governments to recognize the basic healthfulness of biophilic places. And so we're kind of thinking of ourselves as being a bit on the creative edge and trying to change minds. But I'm simultaneously struck by the extent to which the real estate market is already giving us the information. And I'm interested in your kind of take on this, and is this a good starting point for some of the questions you're asking? You can't help but notice in Manhattan, for example, that the highest real estate prices are in big apartment buildings that overlook Central Park.
Of course.
And the rate of gentrification and hyperinvestment around the High Line is extremely valuable market information about the value of, from our point of view, biophilic spaces and green spaces, which of course are directly related to human well-being and community health. So I'm interested in pursuing this from our point of view, from biophilic kind of progress, is how much is the market already telling us and we're just not paying attention? And is it also a question of timing where the real estate market responds after the investors, and maybe there's some alignment that needs to take place? Thanks.
So I think the whole issue of biophilia is a great one in the sense of it's the kind of issue or domain that, again, that's why, what am I asking you to do? I'm asking you to go out and engage and make sure you guys are, please don't wait passively for the healthcare industry to define what this means for health, because we're not going to end up with, we're going to end up with somewhat unsatisfying results. We won't pick up naturally things like biophilic design, which I think is actually, as a human being, will be that will be a part of both high performance, but I also think it's, well, my guess is it will also, it might actually drive value in terms of the actual perceived value of a property more than some of the things that a traditional public health approach would identify as most important. So I think it's really important. The second thing that I wanted to say was, I think there's an anecdote that I just really enjoy specifically around biophilic design, which I think is part of why I want us to think not just at an individual scale, but a population scale. My example was an interaction I had with Anthony Ravitz, who's a senior person for real estate management at Google. And I heard him last year at Greenbuild. We were standing in the back at a session on biophilic design. We were watching this session with these amazing projects being demonstrated. Of office buildings were biophilic and cutting edge and so forth. And they were very varied and so forth. And I stood in the back and I was like, isn't this amazing, Anthony? These are incredible. And he said, it is. He says, but they're still not getting what I have to make, the decision I have to make related to biophilic design. He says, a half a millisecond a year, I have Larry Page's attention. And the only thing he asked me related to biophilic design is, tell me about our coolest thing? No. He says, oh, Anthony, are all of our properties biophilic across Asia, Europe, US? And I have to say, yes. And that doesn't mean every individual detail. It means, was there a process followed that systematically thought through biophilic design and predictably delivers good biophilic design in a culturally appropriate way for that office and resource? That's what we're kind of going at. So I think those are the types, so that particular issue is very important.
I'll go right to the money part of what you were implying. So I totally get that. And I go to the money place, basically saying, look, I think one of your points is there is a lot of implicit pricing, whether in terms of people are already voting with their wallets for these qualities. And that's one of the reasons that yet that implicit, we know that. There's lots of hedonic studies of showing us that homes near parks, they have elevated pricing, and they think, but there's a disconnect there, right? We understand distance to park. We kind of get the walk score thing, like last year's study by Real Capital Analytics and walk score showing a commercial market differential for walkability. So yes, there is pricing, and actually that's one of the reasons that notion that I was saying earlier, that the reason people participate in GRESP is, and moreover, the fact that once they participate, there is a spread. There's a spread. Like the fact that there is a spread, and that a smart investor who can get these data can arbitrage the spread and make money because they're using information that their competitors are not using. We're kind of in a moment where you can arbitrage this. There is missing information, like you said, access to green, biophilic, access to dense and walkable. That information is not being levered as much as it could be. It's circular, as you said, because people say, well, we don't have the data, thus we're not doing the deals, thus we never create the data. So you have to have somebody who breaks you out of this cycle of kind of this dum-dum cycle of like, that can't be true because I have no data. I have no data because everybody, yeah, right. So, but we can break out of that cycle, right? We've done it multiple times before. So everything you said, I think there is implicit pricing. We know that if you took that information into account, it's not everywhere, and that's the other lesson, like from green premium type studies. You get a bigger green premium in Manhattan to reposition assets than you do in Cleveland. So when you take the average of a whole bunch of studies, you don't see like some consistent and cogent response. You have to be a little more nuanced, and that's a world of nuance that brokers and so forth are used to. They don't get this information through the places they normally get information, i.e. it's invisible. So it's this network of problems. There's another sub-problem which some of you guys are involved with, like with appraisal and valuation. You may think that's true. It may be hedonically true, but it doesn't go into an appraisal. Thus, if you try to use it in a lending, residential commercial lending situation, it effectively has no value. You can't monetize. You can't get a loan based on that extra value.
But Chris, I just want to make sure that's very specifically, go find your public health friends who love the built environment and explain what Chris just said. Tell them what matters in your day-to-day practice, because they don't know. They have no idea. Still am learning all the time. Appraisals, oh, that makes sense. As soon as you say it, I get it. But you need to tell us where the moments in your process are that, there's just certain decisions that have to be made, and where are the moments that you need different information, different guidance, different incentives, different contracts. We have to define that together, and then public health will be able to help define those, bring the data to bear for you, I promise. But we do need you guys to help us understand that process better, find the inflection points.
Another perspective to this, which I think is interesting, and by the way, biophilic design is a brand new concept to me. I had to think about what the pieces of the word meant. I love it. I'm going to use it all the time now.
It's a thing, by the way.
It's a thing.
It's a big thing.
Yeah, who knew?
It's a big thing.
One thing I think a lot about,
Real-time education here.
One thing I think a lot about, both my research and otherwise, is the issue of disparities. So your example, and I think it's a good one, of high-rises overlooking Central Park is we need to be careful that these things don't only go to those who can afford them. Yeah. What I like about the work that we're trying to do is that places that don't have access visually or otherwise to green space, we know in our core those people are going to be less healthy or less, again, they're less wellness, let's leave it more loosely. That eventually, there's an externality there, that eventually costs somebody something. Mm-hmm. So that's how, and you're seeing that in some of the designs you saw that I put up, where the facilities being built for low-income people are beautiful. You would want to live there. That's a very different design than what it was years past. But what we haven't done yet is figure out how do we get those who will otherwise have to pay for the downstream consequences of not having a biophilic design, help support that early on amongst those who can't just buy it because they are millionaires.
Can I just say very explicitly too, the answer somewhat is the Affordable Care Act, guys, if you guys are in this room, there's a very specific way of looking at this that I really firmly believe in, and I'm actually writing a perspective piece on this, is right now the Affordable Care Act is going to fundamentally change, as Doug said, the way money is, how it comes out of the healthcare system. You're seeing these early examples of hospitals directly funding projects. I hope you heard that because right now, University of Virginia, where I work, is the literal built environment of it is built out on the entirely wrong healthcare system. Okay, right. There is an opportunity, I think has not existed in a long time, for the architecture and so forth to be directly involved in adapting literally healthcare systems to a totally new way of thinking that includes direct compensation for community health projects. Let that sit and land for a second in terms of so that is part of what we're trying to link into, is all this work is that's going to be a reality, and then all these other pieces also that's why there's urgency around the problems Chris highlighted of getting to a unified, actionable definition of health and wellness at a variety of scales, so that groups like affordable housing groups who are already seeing this coming, they want a systematic process for addressing health that can be certified via green building certification systems, so that they can answer to their own Larry Page saying, did you consider systematically health in a non-random way? Yes. And it manifests differently in each project, but every time, yes. And then, so for that reason, we should be a recipient of Affordable Care Act funding.
So we're just about out of time, but I think we have one more question, and we'll do a quick...
It's a pretty quick question, because you guys have touched on pretty much all the questions I've written down. Tracy Rankin, I don't know what affiliation I am today, GW
Say the
or
big
NIH.
one. Say the big one. Yeah, exactly. From National Institutes of Health. Yeah.
So I'm coming at this from more of the public health perspective, from the clinician side of things. And you have made that, I also learned a new word today, biophilic. Thank you.
Design, yeah.
You've touched on that very important point that we've discussed over our summer about project teams not being held responsible or feeling they have to be responsible for curing obesity, as it were. That said, you, Dr. Judy, showed incredible data from East Lake about the reduction in crime and increased graduation rates. I was just curious what that timeline was to give people a sense of when those changes actually happened in terms of coming back to
So that was
investability.
over 15 years, and actually related to that. So they saw that go from Little Vietnam to now a much safer neighborhood where, again, the kids, these are similarly low-income children, are outperforming neighborhoods where the average home price is $2.5 million. In Atlanta, that's a nice house. Not here in DC or in San Francisco necessarily, but that's a nice house in Atlanta. The other interesting thing and really fascinating about it is that Carol Naughton is the president, and she was actually head of the East Lake Foundation before they really turned into purpose-built. One of the things she said not long ago was that she has noticed herself, this is really anecdotal because they weren't measuring it. It's very common not to measure health because they're real estate developers, right? She said that 15 years ago, everyone in the community was obese, universal. African American, low-income families, that was the definition of obesity 15 years ago, as it is still in most cases now. There's very little obesity now in this community. There was no obesity intervention. There was no clinical approach. There was no study, no teaching.
No overt obesity prevention.
Well, that's the thing, right? But it was done, it was a side effect, practically, of the community becoming well-designed. And so that's a classic example. Now, I'm hoping that we can figure out how to go back in to really prove that. Find out, look at what the kids' weights were years ago through the public health records or something. But it is interesting how the health sort of happened as a result of making the place nicer.
But Tracy, to your point, one of our big challenges for ourselves that we've given ourselves as a team is, as we define things like these process credits to approach health, and why we are working directly with practitioners, and again, why we need you to engage with us, is we know that you can't wait 15 years, for those things. And so what we are working hard to define are suitable proxies that are within your control and that can be influenced in the time scale of a project, that public health, through our literature base, can help you link to those longer term outcomes that we all want. And then I think what we're also hoping to do, as through the process credit, is create an incentive and have it be part of certification, that even though you're not going to wait around to show those long-term things, that we are going to start incentivizing project teams to gather data and contribute it to the county level effort that might be going on, but not hold them responsible for an obesity rate. And that's when I think, actually, the last little thing I would say is, I think another huge opportunity directly for practitioners is, as these types of, we also want to give you credit for considering an option, a health issue in a particular site, and then for a site-specific reason or a client-specific reason that you weren't able to do it. But we want to also show that that consideration was done. And then I also hope over time that if we start seeing patterns where certain health issues that we all care about, that they consistently get valued, engineered out, or left out of a project in a particular context, then that becomes the natural thing at next year's Greenbuild. this shouldn't be left off the table. What are the design strategies and solutions that need to be innovated on?
Well, we want to thank you all very much for joining us this morning, and hope that you learned something new. And we really do want your engagement, whether you work at the project level or you work at the portfolio level or you're from public health and you're still trying to figure it all out. We do want to engage with you. So thanks very much, and have a good rest of your day.
Thank you.
Thank you.